and welcome to Medical Grand Rounds. The Zoom platform worked rather well last week, so we're hoping we will do a repeat performance here and be able to conduct a successful Grand Rounds. Again, I want to remind people what the rules are. The participants or panelists are able to display video and speak and show slides. The audience is muted and their videos are turned off. However, they can participate by using the Q&A button, which you will find on the bottom of your screen. And I will be monitoring for questions during the course of the talk, and we'll come back to them. Now, the last 5 weeks, we converted Grand Rounds into a COVID update. And I thought it was time to start normalizing Grand Rounds a little bit. So the plan today is I will show you 5 or 6 slides related to COVID, just the updates on stats and epidemiology and a little bit of predicting. And then the bulk of the talk will be GI, Dr. Patrick Okolo, who I will introduce to you all in a second. So to start with the statistics, the Monroe County numbers as of yesterday at 4 p.m., there were 1,130 confirmed cases, 98 hospitalizations, 30 in the ICU, and a total of 88 deaths, which had gone up from 82 the day before. So 6 new deaths in 24 hours. That number has stayed pretty much constant for the last few days. At Rochester Regional, as of last evening, there were a total of 52 hospitalized, about 2/3 of them at Rochester General, 1/3 of them at Unity Hospital. 17 patients were discharged yesterday. And then the bottom of the slide there shows you some long-term care numbers. And we need to be paying attention to this because the long-term care facilities have become a bit of a hotbed for COVID. So this slide is similar to the one that Emil has been showing weekly, and it shows you the confirmed COVID midnight census, upper left-hand corner. As you can see, the number has been pretty flat over the last week or so. If you look to the right of the slide, the upper bar graph shows you the number of discharges, which is going up, good news. And then the lower bar graph shows you the number of deaths. These are the total number of tests performed at RRH. So 6,600 tests performed, 5,400 negative, 768 positive, and we have 42 positive employees. So this is a graph showing admissions. So if you look at the red line, that's daily new admissions, which as you can see has gone down a little bit. So that's a good sign, but it does go up and down a little bit. And then the blue bar graph shows you cumulative admissions over time going to April 19th. And then this last slide here shows you the current projections. So if you look at the blue line and the dark yellow line there, they're showing you what's projected in our ICU. So the hospitalizations and the ICU admissions are projected to keep going up somewhat into the next week to 10 days if we continue at the present rate. Now that's presuming the current degree of social distancing. As that opens up a little bit, these curves may shift upward a little. So we just need to be cautious of that and be monitoring that. So with that, I am going to stop sharing my slide and let Dr. Okolo go on. And in the meantime, tell you that Dr. Patrick Okolo has been a great addition to Rochester Regional. He joined us as the system chair of gastroenterology, and he's been a fine addition to the team. His specialty is advanced endoscopy, and he's able to do some rather innovative things, including endoscopic treatment for obesity, for bariatric. So this is intended for people who might not yet qualify for bariatric surgery, but these are simpler endoscopic treatments. The topic today, though, is not that. He will be telling us about gastroesophageal reflux disease and some innovative approaches to that common disease, wide spectrum. Dr. Okolo.
Fantastic. Thank you very much, Brad, and thank you very much to everyone. I hope you can see my screen. I will try to get through a very broad topic and try to get through it in a succinct manner without rushing. I think we all know what reflux is. The definition of reflux comes from the Montreal classification for reflux. And basically, it's just the reflux of gastric contents such that it causes symptoms with or without complications. And there are various manifestations of reflux, which is really the heart of my talk, from nuisance heartburn all the way to different symptomatic syndromes and the occasional adenocarcinoma that results from reflux disease. So in going through it, stomach contents which usually have a low pH, a reflux into the esophagus typically, and that causes, as you can see, heartburn, regurgitation, and water brash. Water brash is an autonomic response to the presence of refluxate in the esophagus and can be quite bothersome to patients. On the right side of the slide, you have the complications of reflux, which I had mentioned earlier. Mucosal damage resulting in luminal compromise and reflux strictures, Barrett's esophagus, where there's a change in the lining of the esophagus and subsequently esophageal adenocarcinoma. The mainstay of treatment in North America and much of the world has been proton pump inhibitors. Again, a symptom map of reflux. So in taking one step back, I've been lucky to live in this country for the last 3 decades. It certainly looks, when one looks from a Google map point of view, from a high level point of view, that in much of the world, as with the United States, the prevalence of reflux, as it's often a prevalent rather than an incident disease, has been going up over time. And this is what the world looks like. Most of the world's refluxes appear to live in the Americas, and that's true for both North and South America, parts of Western Europe, and there is much less, but not insignificant, footprint of reflux on the Indian subcontinent and in Australia. And so this trend really clearly shows that when you use survey data, that this has been increasing. So I'm trying to justify presenting it as a ground rounds topic. And when I arrived on the shores of this country in 1990, the prevalence of reflux as using proportion of visits to primary care doctors as a surrogate was about 1.7% of all visits. In the last decade, we'll wait for this last decade's figures, but the decade before that, it accounted for as much as 1/5 of all, of some component of all visits to primary care doctors throughout the country, showing that even though this is a surrogate measure, this likely is a true increase. And if you look downstream at some of the downstream consequences, looking at cancers, which is the ultimate complication, the ultimate awful complication of reflux, you have both a real increase in esophageal adenocarcinoma and a more muted trend increase as well in cancers of the gastric cardia. What's the reason for this? I think clearly the population is aging, and that might be contributing to this. But we think that one of the strongest signals is the increasing body mass index of the American. There might be other issues related to diet, related to lifestyle, and clearly the decreasing prevalence of Helicobacter pylori, which sounds counterintuitive, but if time permits, that is something that we can speculate about. This is a trend view of what's happening. Helicobacter pylori infection is going down, particularly in younger cohorts of Americans. As a result, gastric adenocarcinoma is decreasing. Unfortunately, we see increase in reflux, increase in esophageal adenocarcinoma as a consequence of Barrett's esophagus. This is not a political map. It is the trend line of obesity and overweight as by the NHANES survey. And you can see what the 1990s looked like, with the blue being lower levels of overweight and obesity. In 30 years, most of the countries turned red, meaning that there's greater than 25% obesity, with some states now turning purple, which is a new designation where there is more than 40% obesity. So clearly, this is mirrored in the rate of what reflux is going to do. Looking down the road at our younger Americans to get a sense of what will happen in 10 to 20 years, you can see that there's a true increase in the adolescents and a juvenile population. So reflux is cogent, reflux is here, causes significant perturbation of quality of life when it is mild, causes significant morbidity when it is severe. And I'd like to speak with you about recognizing different lanes of reflux and talking about innovative treatments. Significant problem. I think everyone's convinced about that at the moment. Most of the patients are treated with medications. These medications have become interesting in the lay literature, and I'd like to just address those as well, and then contrast the footprint of procedures and when interventional procedures may be necessary or important or helpful for patients, if you will. So the objective of treatment is to take symptoms away, improve health-related quality of life, patient satisfaction, and all of that. And the ways that we assess objective improvement is to see an improvement in the resolution of identified pathology and in a decrease in the quantitation, if you will, of refluxed acid into the esophagus. And I'll chat to you about that very quickly. The pathophysiology, will not spend too much time on this. Usually there is a competent lower esophageal sphincter. This is actually a group of muscles as opposed to one muscle for the medical resident. It's supposed to be a one-way valve going from proximal to distal or from north to south. When it becomes incompetent, it becomes a two-way valve, allowing the reflux of gastric contents proximally. It can happen because there is hypotension at the lower esophageal sphincter, or because the pressure within the stomach is greater than the natural pressure of the lower esophageal sphincter. Or it can happen because there's abnormal electricity, and there are these electrical impulses that we call transient lower esophageal sphincter relaxations that allow reflux to happen. Delayed gastric emptying will also contribute to this by making more acid available for reflux. Clearly, a hiatal hernia, by definition, reduces the competence of the lower esophageal sphincter. I won't spend too much time on the nitty-gritty of this, but talk about the diagnostic evaluation of reflux. Basically, most reflux is identified by the presence of symptoms. In terms of objective findings, we look at upper endoscopy to look at mucosal morphology and to see if there's mucosal injury, and or for the complications of reflux, such as a stricture, and in some cases, the presence of Barrett's. Endoscopy is highly specific. However, its sensitivity is low because a good majority of patients, about 50 plus % of patients, do not have any endoscopic correlates. So we often perform endoscopy to look for the presence of other diagnoses as well. The mainstay of reflux and the gold standard is ambulatory pH monitoring. Can you measure the amount of acid that is being refluxed up? We think that you should, in normalcy, reflux less than 4% of the time. And so if you have more than 4% of gastric reflux into the esophagus, you clearly will begin to experience symptoms. The correlation of the acid exposure to symptoms is also very important, and we'll talk about that. So we also look for non-acid reflux, which can be an issue in some patients. We'll talk about that. So the main body of my talk is about acid reflux, and we look for the presence of motility changes and the appearance of gastric contents, regardless of their pH, into inappropriate spaces. Let's see if this will play. This is the way that we do these days. I hope you can see the animation. Instead of having a patient have a small wired device into the esophagus, we do this now in the context of an upper endoscopy. We perform an upper endoscopy and then put this device in called the Bravo pH meter. It is deployed by the endoscopist, and he or she will attach this 6 centimeters above the lower esophageal sphincter. This device has the ability to measure pH and to send this using a weak frequency modulator, so an FM signal to a device that the patient is wearing on their person. And this measures acid refluxate for a period of 72 to 96 hours. The patient's able to keep a diary. Doesn't have anything showing up, doesn't have anything bothering them, and often, so this has changed things for us in terms of being able to reliably, when the clinical situation calls for it, measure acid exposure. These are the different clinical phenotypes. I think that all clinicians and most people in the audience will realize that not all reflux is the same, and it's different strokes for different folks. Most patients will be basically heartburn predominant. There are those who are regurgitation predominant. And in the regurgitation predominant group of patients is where we see the difficult to control patients, difficult to control symptoms, and we also see the extraesophageal manifestations of reflux, including voice box problems. There is clearly a contribution of reflux to those with reactive airways disease, particularly in the young, and so you get exacerbation of asthma and other respiratory problems, aspiration pneumonia in certain patients. This group of patients, or these groups of patients, are clearly very different from patients who we can treat very easily from the point of view of heartburn. I'd like to concentrate on the latter group, just another schematic of these different phenotypes. I won't waste too much time with that because I think the point's been made. And talk about why a patient may seek to leave pharmacology and look for other things. And so we learned from the surgical approach. And in the surgical approach, surgery was often performed for those patients whose symptoms could not be controlled, particularly regurgitators. These were patients with very high volume reflux. Also patients who were sensitive to medications and had idiosyncratic side effects from these medications. And clearly, for those patients who are also anxious about long-term medications, these were all the different impetuses, if you will, for surgical treatment. Clearly, those with extraesophageal manifestation, particularly cough. And so if to go to surgery, you would have to confirm the diagnosis and make sure that this was reflux and not some other phenomenon. And the traditional treatment was some sort of improvement in the physiology of the gastroesophageal valve by forming a mechanical barrier to reflux. And this is often effective in 8 to 9 out of 10 patients. However, there's a failure rate over years, and this has been a dissatisfier with the surgical approach. If there are surgeons in the audience, they often get a little bit irked by this slide. But this is the way that we see it in gastroenterology. We tend to see these patients several years after anti-reflux surgery, and there's a fail rate as the years go by. However, it is true that prior to some of the things I would show you, that laparoscopic Nissen fundoplication became the gold standard for treating patients with this type of reflux. We've talked about these indications, and this is the SAGES statements. The SAGES is the official society for gastrointestinal surgeons. I think for those patients who have difficult to control reflux, patients with large hiatal hernia, and some of the things we talked about are those patients that we consider for procedural interventions. So having learned from what the surgeons do, and this is a schematic of the different things they do, take some of the stomach, wrap around the lower esophagus in an attempt, which is often successful attempt, to improve the competence of this valve. These are also the things we've learned, is that a number of these patients will develop dysphagia and gas bloat syndrome, and some of them will develop some fairly significant complications. In terms of how this stacks up against medications, you see that clearly surgery is more effective both for symptom control and for complication control than traditional pharmacologic therapy. And so just going on and skipping through some of these slides, this is just more randomized clinical trial evidence that anti-reflux surgery works, especially relative to medical treatment. We, however, cannot subject but a few patients to operations. And so this got gastroenterologists thinking, especially in light of what was happening, especially in light of the response to the New York Times suggesting that there was a significant problem with proton pump inhibitors. I put this slide in there because often I get questions about this. When a large randomized clinical trial of over 17,000 Canadian patients were looked at, proton pump inhibitors are indeed safe. So I'm not suggesting by any means that they're not safe. The one thing that we did show from this study is that proton pump inhibitors are associated with changes in intestinal microbiota. And as a result, C. diff may become 30% more severe than in patients who were not taking proton pump inhibitors. So this is clearly one thing that you can say PPIs cause. But the impetus for endoscopic therapy is really to control symptoms. And in those patients who are regurgitation predominant and who have extraesophageal manifestations, to see if we can control their symptoms without pharmacology and without subjecting them to surgery. And so these are the different things we tried. Injecting things into the lower esophageal sphincter, sewing the lower esophageal sphincter, and then more recently, transoral endoscopic fundoplication, which I'd like to chat to you about in the next few minutes. This was the injection. It was injecting a polymer to bulk up the lower esophageal sphincter. Very easy to do. It took about 5 minutes. It worked in expert hands. The problem is that the aorta is right behind the esophagus, and the potential to inject this polymer into the esophagus, into the aorta was a problem. And so this was withdrawn by the FDA. Radiofrequency energy to the lower esophageal sphincter. This does not change esophageal acid exposure, but appears to numb the esophagus, and this has been largely abandoned. So these procedures were all tried. They all did not work, and all went away, withdrawn by the FDA, or the companies went bankrupt. And so for a while, and those of you may recognize the dodo from my parts of the world, endoscopic treatment was as dead as the dodo. However, these new platforms, and I'll spend the next 10 minutes or so talking to you about this, and then we'll allow time for questions, were the Medigos platform. And in the Medigos platform, came out of Israel, and the idea was to put an endoscope into the stomach, use a proprietary endoscope which had a magnet to it to recruit parts of the stomach. And you can see in this animation how that's done. There is another magnet on the other. You can see the magnet on the shaft of the endoscope. That second magnet sits at the lower esophageal sphincter. You're able to take parts of the stomach and using that magnetic force, align both of them. And by doing this in a circumferential or hemicircumferential manner, you're able to form a fundoplication, very much in the same way that surgeons did that. This was very much like flying with instruments as opposed to flying visually. Most endoscopists are visual people, and so this was a platform driven by these magnets and computers and artificial intelligence, and very robust, but somewhat very difficult and very expensive. And even though the parameters were quite good, this has been largely abandoned. But he gave us the impetus based on this to show that you actually decrease esophageal acid exposure, the golden fleece of treating reflux. And so the Muse trial and the follow-up showed that this was robust. And what this did was to give people the hubris, if you will, to go on to treatment. This is a treatment that comes from northern India, from Hyderabad. And in Hyderabad, for those patients who have no hiatal hernia, by simply removing the mucosa of the proximal stomach around the lower esophageal sphincter, the remodeling that is done leaves the patient with a newly imbued strength to the gastroesophageal valve. And so friends of mine like Dr. Reddy in India have pioneered this technique. The problem is that there are few candidates for this sort of technique. You have to have absolutely no hiatal hernia to do this. It takes about 15 minutes to do. Bleeding is the only complication which we see in less than 2% of patients. The problem is that this is, the patient selection for this particular technique is rather stringent. And so it works, as I said, and it's a very easy thing to do, and it's within the purview of most gastroenterologists, since it really just involves resecting the mucosa. And to make sure that we don't go too deep, we have ways of doing that. This is just the way it's done. You resect the mucosa above the band, and that way you don't go too deep, etc. It's worth mentioning that there are magnets that can be placed surgically into the esophagus, and this also works, just in case I get questions about that. The RESPECT trial was from 8 US centers, shows that these worked in terms of reducing regurgitation. And so what this did was to say to us, well, if all these things work, can we simulate what happens at surgery? Can we do that endoscopically? Can we do that in a way that's reliable? And this is what we came up with after several iterations. This is the Transoral fundoplication device, something that we'll be doing here at Rochester Regional, very shortly. And it's a device that carries an endoscope. The endoscope allows you to drive safely through the esophagus. Patients lying down, you perform this, usually under deep sedation or general anesthesia. You retroflex, meaning that you're looking from distal to proximal at the lower esophageal sphincter and the gastric cardia. You're able to recruit parts of the esophagus, reduce the hiatal hernia by bringing the esophagus back below the diaphragm. and then coupling gastric fundus to that newly reduced part of the hiatal hernia. So you're fixing the hiatal hernia and augmenting the lower esophageal sphincter. And we do this all endoscopically, and you can see how you tack the pledgets on to keep things in place. These are propylene sutures, which you're able to do. This you then do in a hemicircumferential 270-degree fashion. And what you're doing is creating an endoscopic fundoplication in the same way that the toupee operation is done. And so we do this all endoscopically. It takes about an hour to do. You can do this in the endoscopy unit, and it's often quite effective. So the RESPECT trial, other trials using randomized clinical trial and grade A evidence showed that there was clear benefit to doing this. And when we took the phenotype of patients who were major regurgitation patients, you saw a 67% response to the endoscopic arm, as opposed to 45% for the usual treatment proton pump inhibitor arm, which means that there was an attributable risk reduction of 22%. Those of you who like to calculate numbers needed to treat will see that that's a number needed to treat of less than 5. And so rather robust grade A evidence that this does work. It looked at both objective as well as subjective measures, and we showed clear improvement in elimination of troublesome regurgitation, improvement in acid exposure to the esophagus. This was confirmed in the TEMPO trial, confirmed using the registry information, and clearly the European data as well. How does it work? It works by improving LES pressure, and when we look at all of the different parameters, it works by decreasing them. Visually, you can see on the left-hand side what the esophagus looks like. It's rather loose, and you can see the space around the endoscope if you're looking at that. Lots of space at the beginning of the procedure. At the end of the procedure, the stomach and the esophagus are quite tight around the endoscope, allowing for no trouble with eating, but protective against reflux. I'll jump over that. I'll jump over this as well, since it's a rather specific thing. I think one of the things I'd like to mention is for those patients with gastroparesis, for patients who have gastroparesis making their treatment difficult, we may have different options for them as well, because medications do not work, but by performing other endoscopic interventions, we may improve their lot. The Stretta system we've talked about, and I think it's not helpful. Links, in all fairness, is done laparoscopically and may be a reasonable alternative for some of these endoscopic procedures, and so we discuss this with our patients. I think it is reasonable for me to stop at this point, if you will, and I think looking at the time, I'd like to make sure that we don't go over time, and I will have Prad take over again, and we'll answer any questions about this. But thank you very much for your attention.
So we do have a couple of questions. I do want to tell people, with this invitation for grand rounds, there was an evaluation form. So please fill that out and send it in. Certainly if you want CME for this, that's the only way for me to get you CME. In addition to that though, I would really like to know how these are being received. So, what's the quality of the presentation? Did the videos come across okay? I'd like to hear that from as large a group as possible, so we can tell how effective these are. At my end, it was flawless. It was wonderful. But I'd like to see that that was the case generally. So moving to the questions here, we commonly see patients with typical GERD but EGD does not show any abnormality. We might need pH monitoring to look for it. How commonly available is that at our RGH practices?
I think fantastic. And sorry, up on the screen, if you can still see it, it's my cricketing days on the Nigerian national team. Yes, I think this will become very available soon. In fact, we're going to be setting up a reflux clinic, which will be multidisciplinary, with Alok Gandhi in general surgery and Lisa, whose last name I forget, in thoracic surgery. And so the long and short of this is that we'll make this quite available at all of our different campuses. And we should be able to get patients appropriately in a protocolized fashion to get pH measuring. So very soon, post-COVID, it will be quite available to all of us.
Okay. So please use the Q&A button rather than the chat button for your questions, because that channels to the right place. So the next question is, do you ever use metoclopramide, so Reglan?
Fantastic question. I don't. I don't for a number of reasons. I don't because of the risk of tardive dyskinesia, which can be seen in a few patients. The problem with tardive dyskinesia is that it may not go away when you withdraw the medication. And the number one cause for malpractice litigation in gastroenterology for many years was the use of metoclopramide. And so all it takes is to see one patient who develops Parkinson-like symptoms even after withdrawal of the drug. But let's forget about that for a moment. The second is, does it work? It may work, but it is often followed by very predictable tachyphylaxis. So if it works, it'll work for a short period of time. After that, there is massive tachyphylaxis with this drug, and so it doesn't help. So I often will not use metoclopramide. I haven't used it for about 20 years for these reasons. It's a good question, though, and I think that domperidone, which is not available easily in the United States, and sometimes prucalopride, which is available but indicated for another purpose, are the medicines that we'd like to consider in the group of patients where there is a gastroparesis in association with reflux. So it's an excellent question, but that's my take on it.
Thank you. The next question by Dr. Stearns, surgical fundoplication is sometimes complicated by dysphagia. What are the long-term results for the endoscopic procedure?
That's excellent question, Dr. Stearns. We have not seen dysphagia with the endoscopic procedure. So I think what we've seen is it's a bulky device, and there is a slight uptake. Upper endoscopy is associated with perforation at a very, very low rate, 1 out of 10,000 or less. I think that there is probably 3 to 4 out of 10,000 is the risk, which with this procedure. So it's a small risk, but it's a tripling of the standard risk. And so that's what we see as a problem with transoral fundoplication. But we have not seen dysphagia, and we have not seen gas bloat syndrome, perhaps because of the way it's done, and perhaps more importantly because of patient selection. But we haven't seen dysphagia. And Dr. Stearns, I think that's an excellent question. Thank you for it.
And Dr. Hicks asked, if you have a patient with a history of reflux that's well controlled on a PPI, how often do you need to do EGDs to ensure that nothing is changing and there's no pathology?
This is Dr. Hicks. Thank you for that question. It's a question that many of my colleagues get annoyed when I answer, particularly in national or international fora. The truth of the matter is that Barrett's esophagus, which is the impetus for doing ongoing endoscopy in most, it's often a disease that you find the first time that you endoscope a patient. So the idea of transformation to Barrett's is a very unusual phenomenon. And even though at the moment I have 2 Ivy League tuitions to pay, there is very little impetus for ongoing endoscopy in patients who are, especially patients who are well controlled in the absence of a family history. So for patients who are stable, if they are Caucasian, male, smokers, or have a family history of reflux, of adenocarcinoma, you should definitely do a one-time endoscopy at about 5 years of having reflux, or you can extrapolate those 5 years. If they have Barrett's, then they need ongoing surveillance. But if the initial upper endoscopy was negative, there is almost no scientific impetus for ongoing endoscopy. This is done very much around the country, but there's really nothing that a patient gains from doing that if they have had their primary endoscopy and there is no evidence of Barrett's. So an excellent question.
So a sort of related question here, does chronic therapy with PPIs do more than symptom relief? Does it actually prevent Barrett's and esophageal adenocarcinomas?
This is a very difficult question because the evidence for that is weak. However, there is other evidence to show that there is a correlation between volume of reflux and the footprint of Barrett's and adenocarcinoma. However, what is difficult to show is that attributable risk reduction based on the intervention when you're doing it in a prospective fashion. So we know that reflux is not good for patients, and the higher the volume of reflux, the worse it is. What we've had difficulty showing is decreasing these at time A and following patients out through to time B. So to be scientifically fair, we've had difficulty showing this. We can see the opposite in a natural history experiment, though, that untreated reflux, especially the more volume it is, you get more problems. So we think it's quite good to treat. Just what I can't do is purport that we decrease cancer by that much.
So the next question here, once the voice box is damaged, could it be reversed with treatment of GERD?
It can. That's an excellent question. It certainly can. And we know from, this is something that singers are very worried about. I was in New York City for a few years and treated many people personally who were very worried about this particular phenomenon. I think if you can catch people early and once there are no structural changes, their voices can, with therapy, return. The problem is once they develop nodules, once they develop polyps, once they develop structural changes around the voice box, then they will have long-term changes that may or may not be reversible. But for the most part, some vigilance and early treatment will give them the versatility and that they want. So the answer is generally yes.
So can you elaborate on the decreasing H. pylori prevalence?
Oh, that's a fantastic question. So, yes, there are two things, because we have to make sure that things are not what we call ecologic fallacy, for those of you who are interested in epidemiology. But what we've seen is, because there are two phenomena, over time, like if you look at Americans who are 80 years and above, about half of them have H. pylori. If you look at Americans who are less than 10 years old, very few of them have H. pylori because life has improved. So we want to make sure it's not just a temporal trend, as opposed to something that is cause and effect. We know it's cause and effect because if we treat patients, if you take a population of GERD patients and they have Helicobacter pylori, based on the test and treat strategy and the things that have been pushed over the years, they become more symptomatic after you clear their H. pylori. And we think that is due to a number of molecular and pathophysiologic mechanisms. Perhaps the organism itself does affect the amount of gastric acid you produce, and somehow it affects refluxate. But clearing Helicobacter pylori does two things. It clearly increases the amount of refluxate, and it makes patients more symptomatic for the same amount of refluxate. So it's been shown and clearly proven to be provocative for those kinds of patients. And so H. pylori should be treated for other reasons, should not be treated to improve reflux, as it often does the opposite.
So 2 or 3 questions here about H2 blockers. We didn't discuss those very much. Is there a role for those? Do you sometimes combine those with PPIs?
That's another excellent question. Yes, the answer to that is yes. H2 RAs work for about 2/3 of patients, so it leaves about 1/3 of patients untreated. There were major advances when they were there, but when they were first available. But it leaves about 1/3 of patients uncontrolled. PPIs have improved that to about 90+%. There are patients who have nocturnal acid breakthrough. Nocturnal acid breakthrough is where the proton pumps have been blocked, and then usually at night, the patient produces acid using the histamine pathway. And so for those patients who have nocturnal acid breakthrough, we'll treat with a proton pump inhibitor in the morning and an H2 receptor antagonist at night to block the phenomenon of nocturnal acid breakthrough. And we would use this often together. Now, many of these patients may not have reflux and may hurt or have symptoms for other reasons. And so it's important for this group of patients to have some objective data so that you can understand when they respond and when they don't respond. And so these are the kinds of patients we'd like to see in our new reflux clinic. But the short answer, sorry for being loquacious, is that we do indeed use it in appropriate circumstances together.
Is the endoscopic procedure possible in those who've had the surgery before?
I've done that twice and reported on that. It is possible. Sometimes it is actually technically easier to do, but these things should not be done, without due consideration. One of the things I did not say was that there is a technical limit to the amount of hiatal hernia that we can reduce. And we think that that technical limit is about 3 centimeters. So as long as a hiatal hernia is 3 centimeters or less, and it is not too wide, there is not part of the diaphragm involved, we think we can do these for patients. Insurance companies will sometimes be shy about paying for these, even though cost efficacy has been shown. So in the appropriate patients, the answer is yes, and it can be done after surgery sometimes, as long as the hiatal hernia is less than 3 centimeters.
Great. So last question here by Dr. Koretz. Does long-term use of PPIs lead to osteoporosis?
Very good question. And for those in the audience, this concern about osteoporosis started after an English study showing that there was an increase in hip fractures in people in care homes, what we'll call nursing homes in this country. I think the problem with that is that often the group of patients who are on proton pump inhibitors are older patients. And so it was important to know that this is true and related as opposed to true and unrelated. In terms of the pathophysiology and vitamin D and calcium metabolism and kinetics, we do not think, based on the Canadian study that I showed and a number of other studies, that this is causative. And so there is little pathophysiologic impetus in terms of biologic plausibility that this is contributory to the osteoporosis we see, in spite of lots of anecdotal data. But when you actually look at it based on randomized clinical data, and long-term data, there is no signal that's attributable to proton pump inhibitors. So we don't think that that they cause them.
All right. Well, I saw a peak of 155 participants on this, which is not bad. That's
not bad at all. Not bad at all. I thank everyone for their time. Yes.
That's about as many as we ever got in person in the Twig Auditorium. I got a comment that said, "This works so well, why don't you just keep doing it this way, even if social distancing changes?" And I think we should think about that, because with all the different locations that people are at, it might make it a lot easier for them to attend this type of CME if we continue to provide this kind of format. So for the foreseeable future, for the rest of this academic year, this is how Grand Rounds is going to be. So thank you for participating, and maybe get the word out that we are looking to increase the audience and increase the participation in this. I got a couple of seconds coming through there on the texts. The recording helps as well, I think, and we can let people watch afterward. It's a little more difficult to control CME this way, but I think we can find a way. So thank you for participation, and thank you again, Dr. Okolo. That was a wonderful talk.
Thank you very much indeed for the invitation. Thank you. Thank you very much.
And next week, we might get back to more of a COVID update, depending on what's going on, versus another topic. So see you next week.
Thank you. Have a lovely one. Thank you.